Hello and welcome. I'm Dr. Seemal Desai, a board-certified dermatologist in private and academic practice in Dallas, Texas. I'm the president of the Global Vitiligo Foundation, and I'm joined today by my friend and colleague, Dr. Andrew Alexis, Professor of Clinical Dermatology at Weill Cornell Medical School in New York. Andrew, great to have you here.
Great to see you, Seemal.
So let's dive in, because we're going to talk today about vitiligo. And this is an area of deep passion for me, for Andrew as well, both of us as skin of color experts, and where we've dedicated our time into research and new findings. But what we want to share today is a little bit about maybe taking a step back from treatment and going a little bit to the beginning of the vitiligo visit, Andrew. And what I thought we could cover is talking about the burden of the disease, but from a perspective of comorbidities. And we've talked a lot about vitiligo, and I'm very passionate about this being a disease, an autoimmune, auto-inflammatory condition, but that's linked to other comorbidities. And I thought this would be a great opportunity for us to talk about that. So why don't you start? Tell us a little bit about what you view as comorbidities with vitiligo.
Yeah, great. Happy to do that. And as you said, Seemal, we recognize vitiligo is an autoimmune disorder. And one of the great pieces of evidence that we see in our practice taking care of patients is that many patients with vitiligo will also have other autoimmune conditions.
Exactly.
And I think thyroid disorders really are among the top of the list. So I'll routinely screen patients for autoimmune thyroid disorders. Of course, there are others.
Yeah, and thyroid, I agree with you, is for the first one, but you're right, there are others. Of course, type 1 diabetes, some of the other things like rheumatoid arthritis, really talking about that autoimmune history. Do you do that with your patients as well? Kind of dig into the history a little bit?
Yeah, absolutely. I want to take a very detailed history about personal and family history of autoimmune disorders. And we'll uncover patients, in addition to thyroid, which comes up quite frequently. In addition to that, as you said, type 1 diabetes can come up. Even connective tissue disorders, like lupus, might be of higher frequency. We might see pernicious anemia.
Yes.
And although not an autoimmune comorbidity, another comorbidities that we see is low vitamin D. A lot of these patients have very low vitamin D levels.
I'm really glad you said that, because I want to come back to that in just a minute when we talk about lab testing. But you also mentioned connective tissue, and I'm glad you did, because we don't traditionally think about lupus, lichen planus, those sort of things as quote unquote comorbidities. But you're absolutely right. We do see those diseases co-localized a lot together. And we've published on that, and there's been several case reports, including showing concomitant vitiligo and lichen planus. There's also been a lot of case reports showing vitiligo and forms of cutaneous lupus, like Andrew said, specifically subacute cutaneous lupus erythematosus, especially for those patients who are in phototherapy. I can tell you a case where I actually induced lupus in an SCLE presentation in a patient because they were coming for vitiligo, and we put them in narrowband UVB, and we induced a photosensitive response. And so really glad you mentioned connective tissue, because comorbidities and co-localized disease are something that I think we need to broadly think about for these individuals as well. I'm sure you've seen some of those also.
Yeah, absolutely. And let's not forget dermatologic conditions that are immune mediated that we might see together with vitiligo, like alopecia areata being another autoimmune disorder that we might see in the same patient that has vitiligo. Do you see that as well?
I have seen several cases of alopecia areata and vitiligo, and remember, they're both type 1 mediated CD8 T cell diseases. They're interferon gamma. And it's funny you say that, because that's actually why when you explain to patients that you're going to use a JAK inhibitor, that it makes sense, because they're immunologically in that same family of diseases. And so I love where we're going with this, which is, yes, comorbidities, underlying systemic disease, but there are also underlying dermatologic diseases that can be mixed in with vitiligo as well. So let's switch gears a little bit and talk about lab screening. And I want to preface this by saying that everyone does it differently. Even amongst us pigmentary diseases experts, we all do it very, very differently. So what is your sort of baseline lab screening, if any, let's say for a brand new vitiligo patient who's never been to a dermatologist who's coming to see you?
Sure. My basic screening, and of course this would be tailored depending on the patient history, maybe more things would be added, but as a basic screen, a CBC with diff, TSH,
Yep.
hemoglobin A1C, and I go back and forth about the ANA. Because it often can bring up some. It could be positive and not clinically relevant, but in any event, I frequently do include an ANA.
Okay, so that's really interesting. I'm the same way about ANA. I usually don't do it because I don't know if it's a low titer, what I'm really going to do with that. That being said, that patient who got SCLE, had I probably done an ANA in advance, I would have known that they've had some underlying autoimmune thing and then maybe gone down the workup pathway. I similarly to you, I definitely check a TSH. I always do a TSH and free T4 at the same time, and I also do a thyroid peroxidase antibody. I have found, and I've started doing TPOs more in the past few years, but I've found many patients with vitiligo who have high TPO titers that are clinically asymptomatic with any thyroid symptoms, and their TSH and T4 are normal. So TSH and free T4 normal, but thyroid peroxidase really high. And so then you say to yourself, what are you going to do with that? And what I usually say is go see an endocrinologist, because I want to make sure that you don't have any underlying autoimmune thyroiditis. And a lot of times what does happen, in full transparency, is I get a letter back from the endocrinologist, everything's fine, nothing to worry about, we'll just monitor the patient. But I'm hoping that I'm able to catch those brewing autoimmune thyroiditis people early. And everyone doesn't do it. I debate with my other vitiligo friends as well, and everyone does it a little bit differently. I do check a vitamin D, so I'm really glad you mentioned that. And I also sometimes check a ferritin, kind of as an acute phase reactant, because I do find there's some studies on iron deficiency similar to your hemoglobin, your CBC comment as well. What about vitamin D? How do you approach vitamin D and vitiligo and more broadly?
Yeah, so I do include a vitamin D as well.
Great.
And frequently find that it's low and then recommend supplementation.
So same here, and there is good data, and Pearl Grimes has published on that. We published a recent consensus paper, and there's hopefully going to be more data about vitamin D as well. So far what we've covered, Andrew, is thyroid dysfunction, diabetes, rheumatoid arthritis, pernicious anemia, those classic systemic autoimmune diseases, the dermatologic co-localized diseases is probably how I would coin them, and some lab abnormalities. Maybe in the last minute or two that we have together, let's talk a little bit about some tough cases we've seen. And so do you want to share any, you have great cases that you always share in your talks, any recent vitiligo challenges that have come up in your clinic?
Well, I guess with that question, we can uncover one more comorbidity, which is the psychological or psychosocial.
I'm so glad you went there, yes.
And how often do we see patients that come in who are so impacted by the visibility of their vitiligo and how it impacts them in their day-to-day social or professional interactions. And that's usually the key driver for them seeking out a dermatologist who can help them.
And I think to answer your question, even though I know it was a rhetorical and an appropriate one, we see that all the time. Every single day with a vitiligo patient, some sort of psychological mood conversation happens, and it's not uncommon to uncover that. So I would totally agree with you that psychological disease, major depressive disease, mood disturbance, definitely comorbidities. I recently actually had a very challenging case. This was a patient who was coming in, had very disfiguring facial vitiligo. We were able to get her started, and this was a 17-year-old being bullied in school, very low self-esteem. We were able to get her started actually on topical ruxolitinib, which, as you know, is FDA approved, the only FDA approved topical we have for non-segmental vitiligo, ages 12 and above. And really within a few weeks, already started to notice a little bit of improvement. But to your point about the psychological disturbance, what clinically did not look very impactful for her was extremely impactful. That at a 6-week follow-up visit, when we're comparing pictures, she sees little dots of color coming in on her cheek. And I think that message is really important when we talk about keeping patients compliant, because we know that vitiligo, unlike other dermatologic diseases, unlike eczema and psoriasis, et cetera, takes a long time.
Exactly.
It's something that we have to coach and cheerlead on. Do you have any tactics on how you do that?
Yeah, so I really want to set the expectations from the initial consultation that this is going to be more of a marathon than a sprint.
Yes.
And sort of have them anticipate that how we define success. So I'll say, when I see you back in 3 months or 4 months, I'm going to be looking for some pigmented dots within any of the white patches. And when we see that, we're going to be very happy about that, because we know that this is the beginning of the pigmentary machinery being turned back on, and more pigment is to come.
Right.
So I'm constantly encouraging the patients to stay on therapy so we can get more and more of those pigmented spots. And I just saw a patient I guess earlier this week who's about 2 years into the journey, and we're still working on it, but she's thrilled at about 75% improvement at 2 years, but still seeing improvement.
And doing well, right?
And doing well.
Yeah. Well, we could talk for hours about vitiligo. It's obviously a passion for both of us, but thank you for joining Dr. Alexis and I today on this deep dive into comorbidities and other underlying conditions as we continue in our quest to improve the lives of our patients suffering from vitiligo. Until next time, thank you for joining us.